Thank you very much. You've heard two fantastic talks which sets the scene and the challenges which Kamlesh mentioned too. So I'm just going to give an overview as to how much things have changed for all of us in just a decade. And I think that's quite important for us to sort of go forward. So if you think of it, I remember those slides when they said if you had diabetes, that was it. Your beta cells just went down. And we've changed that thought. We now talk about reversal. We have debates whether we should call remission. That's been new because of the research done by Roy Taylor and his group. There is forever a debate about what's the best diet ever. Is it low carbs? Is it low calories? Everything. And as we continue saying, and the best diet in the world is the one you can realistically afford. And that's always the challenge. How can you get affordability in the picture? Metformin is being challenged. In fact, our cardiology colleagues say that it shouldn't be first line. The European Society of Cardiology said if you have type 2 diabetes, it shouldn't be metformin. It should be the other drugs, which was unthinkable, at least when I was in training. There's a new classes of drugs which you've heard about, outcomes. And for the first time, we've got drugs that get genuine outcomes. We've got drugs that disease modify or outcome modify. And then finally, in England or in the UK, we have this organization called NICE, which simply answers a simple question, which is, or works on a simple principle, which is think like a patient, but act like a taxpayer. And thereby comes $1 billion question, what can the taxpayer afford? That's the conversation which always goes around. So this is the big thing. Let's be very honest. You know, I remember, and this is not even a joke, when I was training, the reason I did diabetes, because I thought type 2 diabetes, and my consultant told me this. He said, do you know what, this is easy. Tell people to eat properly, exercise, bit of metformin, bit of sulfonylurea, and give them some insulin. And I said, is that it? And they said, that's it. That's all you need to do. And I said, I can do this for the rest of my life. Then if you see what's happened is this fundamental shift of weight, which has suddenly changed the dynamics as to where we are. And that's a revolution, pharmacotherapy, happening today. We're all having discussions around it, and we haven't even had the other drugs come out, and you know, there's some other molecules coming out. So as Kamlesh beautifully said, it's not a lack of drugs, it's a lack of drugs in people's lives, which is the bigger challenge. But you can see what's happened, the sales, and you're talking about weight gain or weight loss, sorry, in this context, nearly getting up to bariatric surgery. This has been the fundamental game changer in the world of type 2 diabetes and now obesity. And this is the other one. For the first time, we could turn around and actually show data that certain drug classes made a difference to your long-term outcomes. Again, not something we had with metformin. Definitely we didn't have it with the SUs. We had studies which looked at all risk factors like STINO2 and UKPDS, but nothing specific classes. So now you've got SGLT2s, you've got GLP-1s, all talking about definite disease modifying outcomes. And then you've seen this chart, which is a big chart, and the blue box. Kamlesh took my sort of thunder away with the blue box comment, but it's always quite fascinating. Do you know what is even more fascinating? I always say this, is because all guidelines come out and they have a little bit of a what we call a bit of an escape clause. Do you know what the escape clause is? Is that at the end, which is if the cost is a major issue, can you just use metformin and sulfonylurea? Well, cost is a major issue for everybody unless you can afford to pay it out of your own pocket. So the problem happens when you sort of always, there's evidence and there's the finance balance that you go with innovative treatment. This is happening all around us. Connected insulin pens, digital systems, EHR, electronic health records, all designed to try and make life easier, right? That's the whole point. So I always give this example, and those of you who heard my last talk will have heard this. Is there anybody in the audience who remembers going to a bank and putting in money by hand, cash? Who remembers doing that? Okay. There's a lot of people in this audience who are basically saying, what do you mean money by hand? Because they never have seen money by cash. A lot of people are saying, what do you mean banks? Like beyond an app, there's like a physical building? That's the change. There are people in this audience who will remember, I remember buying a plane ticket, you had to go to a proper place. And they used to give this ticket with lots of papers on it. Right? So technology has changed our lives, and in healthcare that's inevitable, that will happen. So, and those of you will also be long enough to remember there was a time when you had to dip your, urine to find out what the glucose. We then moved to glucose strips. Now we are moving into non-invasive. So it's all an advancement of science to make life better. It's a quality of life metric that's changing as regards technology goes. There's this, we talk about, we want to do all this, and this is innovation, this is coming forward. This is, I don't classify this sort of thing as innovation. I always say this is progression. This is just progression because in all spheres of life, for us, technology has come through. Banks, movies, as I said. How many of you, I remember growing up in India, right? And nowadays people talk about all these new movie stars about having aura and, you know, lots of people. You haven't seen anything. We used to go and watch Amitabh Bachchan movies. That was something. We didn't have anything like Netflix and Amazon and videos and YouTube. You had to go up and line up and you never got a ticket for the first few weeks. That's the change that's happened in our lives. You can sit, you can watch, you can decide, and you can go and watch it at your home, at your own leisure, by pausing it as many. Technology has happened everywhere. Technology is happening in health. Papers to look at, I always say, so this is the big thing. And me and Sir Professor Yagnik at the back was talking about it. What is the big thing people talk about? Artificial intelligence. Everybody, so what has artificial intelligence done? Where is the evidence base? You might want to have a read of these two papers. They're two actually good papers which summarizes the issues with artificial intelligence. But it also opens up other areas. Does artificial intelligence and ChatGPT open up to, for example, compromising proper research? Probably does, right? Because you're writing now theses and papers based on ChatGPT. It's not proper science. So where does technology and innovation fall in? Where does it actually try and deregularize science? It's a very important discussion that needs to be had going forwards. Does it have a role, for example, and we talk about this in the UK, retinal screening? With all the retinal images that we have, can artificial intelligence help predict who is going to have a retinal issue so we can target it? Can artificial intelligence look at who might develop a problem? Precision medicine. Shivani Misra talks a lot about that piece of work. Can those things look at it? And these two papers do tackle this and talk about it. They're interesting concepts of innovation, but if you think about it, a lot of it is designed to do what? A, improve the quality of life, but lessen the burden on us. How many of you have ever seen a movie called Minority Report? Anybody seen Minority Report? Excellent. Tom Cruise. I'll tell you what the movie was about. You could predict the future, who was going to create a crime, and you can go and arrest them before. That's what you're trying to do with a disease, right? You're trying to predict who might be the best chance of picking up a kidney problem or a heart problem. Will science help us? Do we have innovation to do that? So that's a good piece. And from that paper, this summarizes some of the areas of artificial intelligence people are talking about now, the areas where it may work. And I stress the word may because evidence is very important. And I don't think we should forget in our zeal to adopt science the importance of evidence base and science. As I remember going to a talk where a gentleman talked a lot about artificial intelligence, and I always said, how have you validated that? What is the science? So we always get requests, and as mentioned, I do a national role in technology. We get approached by different companies saying, here we have a device, which is amazing. I said, how is it amazing? So if you put your finger on the app, your blood glucose comes up. And I go, that is amazing. That is amazing. Have you done any testing? No. And I went like, well, have you validated it against blood sugar readings? No, we haven't. So how do you know it works? But we think it's a really good idea. I said, yeah, well, of course it's a good idea, but does it work? And I think we need to be very aware of innovation, that question is asked regularly. The thing needs to work. The thing needs to change lives. The thing just doesn't need to exist, and I think that's an important thing. So this particular chart, I always ask people to look at. This paper talks about where in the world of diabetes, any types, could artificial intelligence have a bearing? And this is a lovely paper which just talks about where the possibility may sit. So technology, I'll tell you where we are in the UK. In type 1 diabetes, the role is established. We've got 98% pickup rates. It's a standard of care. We have worked hard to get it there. Okay? It's in type 2 diabetes, it's been put as a cost-effective model for certain cases. The pickup rate, even in that cost-effective zone, is very patchy. And I'll come to that why. There's a potential high in all cases of type 2 diabetes, but the evidence base is sketchy. Would it work in pre-diabetes? Possibly. Would it work in tablet-controlled diet if you used it intermittently to give ideas about diet changes, impact of medication? Possibly. Is there any evidence base to support that? Not really. So you see the sort of discussion that goes on, and quality of metric, and I always talk about technology as saying it's got a progression of science and inevitability around it. These are all the challenges that we have, and Kamlesh touched upon this, which is very important to remember, is that just giving out technology and going for the next big thing widens your existing gaps even more. Okay? But we need to work together to do that. This is data from 2019, 20 and thereabouts in the NHS, where you can see a black child having half the chance of a white child. Asian as well, lower than white child. Same system. Okay? Just to bear in mind. And that's what we need to challenge going forwards. This is where we are now, and that's after 7 years of work where it's all flat. So that's the important piece of work that we need to make sure that we're not jumping from one innovation to another without closing the gaps. So these are the ethnicity gaps I talked about, whether it's white, Asian and black, they're all quite close to each other, that's pumps. But it takes a humongous amount of effort and time. What we always see, as soon as you launch an innovation, the gaps open. The rich will get it first, right? So I'll give you an example. So I obviously work with Dr. Sujoy Ghosh on a lot of issues around India. We're talking to governments and we met some chief ministers and everybody. The conversation, and I've said this in my last talk, there's an India of two types, right? There's an India which watches Shah Rukh Khan movies in multiplexes, which puts a rocket on the moon, right? And can afford anything in diabetes care. There is also something called Bharat, whereby the kids need their insulin and their supplies on a regular basis to be stored in villages so they don't die. That's the dichotomy you're having, and that's not just here, it's everywhere around the planet. So what we're trying to do is, how can you try and narrow that? Does bringing more innovation widen that, or can you get it to more people? So the challenge for type 2 diabetes in my book is the competing issues. It's about, and here's the question, and nobody has to answer this, is that if you have somebody with type 2 diabetes, and I'll ask this question because I've asked in my last session, so I'll do it again. Who in the audience has got a sports car? Anybody got a sports car? Kamlesh? Not yet. Anybody got a sports car? Okay. Who would want a sports car? Yeah? Those of you who want a sports car, why haven't you got a sports car? You want it, why haven't you got it?
Affordable.
Right, that's pretty much it in type 2 diabetes. Because when it comes down to it, you've only got one pot of money. The reason you haven't got a sports car, because you go, well, I've got to pay my house and my fees and my son's tuition and maybe get my wife a Valentine's Day gift or something. That's a bigger priority than getting a sports car. The problem with type 2 diabetes exactly sits with that. In a pot where you're tight, you've got 4 choices on your plate. Do you want to promote lifestyle and remission? Do you want to give an SGLT2 inhibitor, which reduces renal complications and is a disease-modifying drug? Do you want to give a GLP-1 analog, which is a cardiovascular-modifying drug? Or do you want to give a continuous glucose monitor, which could improve your quality of life and thereby your HbA1c? That's your challenge. If CGM was free, everybody would be on it. And there's the challenge. In type 1 diabetes, the challenge is less. You've got type 1 diabetes, okay, the next thing is CGM and then hybrid closed loop. So it's quite straightforward. That's the only game in town, if you have money. So that's the problem that you have in type 2 diabetes about access and innovation going forwards. But let's also consider the other bits. What is the best diet? As I said, the best diet in the world is the one you can afford. Everything else is chat. That's all it is. Those of people who are maintaining diet and extremely well, do you know what they have? Fantastic willpower, backed by some amazing privilege in life. If you're not worried about putting food on your table for your children, you can do lots of maneuvers to have low carb all the time. Right? You can make sure you're making the changes, and so that's the important thing to remember. But how much is behavioral change sustained? How long can you, who's tried a diet? Anybody tried a diet? You tried that? Did it work? It looks like it's worked. No? Nobody's going to commit to that. And nobody knows how to answer this. Shall I say yes or no? What is he going to say? Everybody tries a diet and then you stop. Because it's so difficult to sustain. That's the problem with diets. So evidence-based creation is important to try and help things going along. So important to say that these are the other bits that we need to bear in mind, and I just wanted to flag them. Increasing age with frailty. Age should not be a biomarker of whether you have the most modern treatments. What should be a biomarker is your quality of life and frailty. You might have somebody who's 84, fit and well, dancing, doing, so why not give them everything you can? You might have somebody with 69 with severe Parkinson's, with very poor quality of life. You don't know how long they'll survive. So these are different things to look at. The challenge is this paper which came out, which I love this paper which made me smile, and it crystallizes beautifully the challenge around the globe. Paper which came out which says population health impact of new drugs recommended by NICE in England for 20 years, across everything, not just diabetes, everything. What it's done is actually made population health go the other way. The authors, that's a view from the authors, their view is that if we had invested that money in better social structures, tackling deprivation, you would have had better outcomes. And that's a really tough place to be in, because NICE is also trying to bring in all these new drugs. So this is across cardiology, cancer, everything. It's a fascinating paper which makes us think as to, where are we and what are we trying to do and where we are. But it makes you think about, is innovation doing the thing that it needs to do, or are we, by doing innovation, inviting more people with privilege to go do better? Is that all we are doing? So to summarize, I would say the world is widening hugely. So as part of my work, I don't just work in India, I also have the opportunity to go to South Africa, Kenya, etc. I'm going to give you a little story about how the privilege and the differences we have. I remember coming back from India after having a meeting in Calcutta, etc. We're talking about what shall we do about the kids who need the education. Sujoyda is doing great work, etc. I remember coming off the plane and getting an email in my role from a particular person with type 1 diabetes, not with type 1 diabetes, a clinician who looks after people with type 1 diabetes, who was really annoyed that they hadn't got the exact type of hybrid closed loop. Not that they hadn't got the hybrid closed loop, but the exact type of hybrid closed loop. And that to me is interesting, because you come off a plane in 7 hours and you dialogue, and because it's just two different worlds. In one world I'm talking about how do I get these kids their proper insulin so they don't have stunted growth because they are being given very low carbs because there's not enough insulin in the fridge, which is what we have seen. And on the other hand, having a debate 6 hours later with somebody about why can't I get the tubeless pump again? Different worlds. So type 1 diabetes is seeing it in real time globally, right? And we talked a lot about, so there is a paper coming out which says every person with type 1 diabetes should have a hybrid closed loop. And I'm going like, well, we haven't sorted insulin out yet, let alone CGM, and we're trying to do hybrid closed loop. It's a big debate which needs to happen. And it comes to a decision point, which is what I wanted to say. I think the global health is actually moving in these two spaces. And I love the question that came from Simon, because I think if I had and I say this not because Kamlesh is here, I've always said this, if you had one magic wand to change diabetes care, you invest more in primary care and the settings around it. Everybody knows it. Everybody knows it. But what we do is we never give primary care anything. We always do the other way around. Because that's where it happens. Everybody knows you want to improve amputations, which is the biggest cost of the system. You top load primary care about prevention. That's how it changes things, not by having more foot teams. Everybody knows it, and I know it. I do a national work. But those are the two choices that's coming to governments and places everywhere. You either increase your healthcare spending, whether it's tax-based or insurance-based from the governments, state funding, or you think about, okay, the state will only fund people who are deprived, or you go into generics regarding affordability. Production's done in local places. India do their own pumps and CGM at their own cost. Or you have to decide on priorities. You have to decide, because you don't have the money to everything. Nobody's got the money to everything. That's the problem. And you can choose some, not all. So I think I wanted to finish with that. The benefits in diabetes care is rarely instantaneous. If you look at the papers being done by Wasim and Kamlesh and all that, you see it takes 7, 8, 9 years to get outcomes. That's the problem in diabetes. So I'll finish with that, just to say that innovation is great, but there is a reason why we're not being able to get into people's lives. And this is the decision points that we are all going to come to, not very far away, as to where people sit. I'll finish there just ahead of time. Thank you very much.